Hello, good afternoon. Welcome. I expect some more people, but it's 2 o'clock here in the Netherlands, so we start the meeting. Welcome to the second network meeting of the International Association of Assisted Dying and Mental Disorders. I think we have a very nice program, and because the participants are a bit different from the first network meeting, I will shortly introduce the IAADM, which was founded in 2024 in the Netherlands and Belgium by Kenneth Chambert from Belgium, Richard Houdevoshaar from the Netherlands, Monica Verhofstadt from Belgium, and myself. Unfortunately, Monica Verhofstadt decided to stop her work and also stop the work for IADM. So the executive board consists now of three dedicated men, Kenneth, Richard, and myself. I want to share my short presentation. Can you see it now, Kenneth? Yes? Okay. Let me see if I can. So the executive board, and we have an advisory board. We are trying to install this advisory board in September of this year, and some people have announced to join the advisory board. And from each country where MAID is legalized or is to become legalized, one representative can join the advisory board, which aims to expand the network, provide input to the executive board, and introduce, of course, new ideas and have quite an active role in one or more activities. So if you want to join the advisory board, please mail to info@iaadm.org. Shortly, the mission of IAADM is to foster international multidisciplinary collaboration in education, research, and clinical care regarding MAID for individuals with mental disorders. And we hope to support a clinical, ethical, legal, and societal debate. IAADM is dedicated to 4 core pillars: enhancing the care practices. So, for example, examining how MAID aligns with palliative psychiatric care, advancing research, promoting. Sorry, I also have to let the people go in. So it's quite. Can you also let the people? No. So I have
No,
to do
for some reason I can't do it.
Okay, so I
I'm
will
not
do
an
it
organizer.
altogether. I can multitask, at least I will try. Promoting education training programs in different countries and, of course, engaging societal outreach. We have different activities of the IAADM. We are planning 4 times a year a network meeting, and a network meeting consists of one presentation from a country about legislation and one presentation about research, clinical care, or another interesting topic. And we are planning to have once in the 2 years an international symposium, and the symposium will take place, the first symposium, in 2026. So the program of today is very interesting. We have 2 presenters, one from France and one from Belgium, and we will start with the first presentation. I'm very glad to introduce to you Cécile Hanon. She is an old age psychiatrist. Let me change this. I will stop sharing so I can see you all and I can let the people come in the meeting. Yeah. The first presenter is Cécile Hanon. She's an old age psychiatrist from France, from Paris. She's working there in a mobile unit of old age psychiatry. She's a member of the Center of Clinical Ethics of Ile-de-France. And in the European Psychiatric Association, she's very active. She's a member of the board and executive committee. She's the chair of the Committee of Education and co-chair of the section of old age psychiatry. And she's also a member of the recent task force on euthanasia of the European Psychiatric Association, where I've met her for the first time. And furthermore, at the French Society of Old Age Psychiatry, she's also a member of the board and European liaison officer. She has a significant role in teaching, especially with regard to ethical and moral aspects related to MAID. So we are very, very happy that she will tell us more about the upcoming new legislation in France. Cécile.
Thank you so much for this kind introduction. Thank you to the three of you for your kind invitation, even at the last minute, but it was quite challenging. So
yes.
I'm happy, and a special hello to Florian Ries, which I have been seen for a long time, and Hugo, who is my colleague here connected. Hey, Florian.
Florian, welcome.
So I'm going to share my screen and give you my... Do you see my screen or not yet?
No, not yet.
No, you don't see it. Okay. Do you see it?
Yes.
Yes, you do. Okay.
Oh, wait a minute. I cannot see the presentation now.
Do you see it?
But not yet.
Not yet? No. I am on 4. No? Okay. Then it did work.
Did work, yes.
It did work. And here, you see it?
Now we see it. Yes.
You see it? Okay.
So, yes.
Okay. Okay, so then I'm gonna speak a little bit about this new development of MAID in France. And yeah, the introduction was I have involvement in France and at the European level within the EPA in terms of education and in terms of reflection on MAID. If it does work. You see the slide coming? The next one? Okay, so I wanted to start with a special tribute to my friend Carlos Augusto Mendoza Lima, who suddenly passed away last week. So he was really a defender of human rights and dignity, and very, very active leader in old age psychiatry. So I just wanted to take the opportunity of this presentation today to say again that his immense humanity, his generosity, and everything left an indelible mark on all those who met him. And we really lost a big voice of Europe and old age psychiatry. And also I lost a very good friend. I guess the animation is not working. Okay, so just to start, there's many movies about the subject. So I just picked some of those movies about the subject. So you might have seen or not seen some of them, just to stress that it's very important on the cultural aspect of every countries. And even in France, where you have some French recent movies about this the topic, that those are not in English, so you might not have heard of them. And I tried to collect a map, a European map of the current situation of euthanasia and assisted suicide in Europe, with in blue the countries where euthanasia is legalized, the orange when this is assisted suicide which is legalized, and in turquoise the countries where it is still in debate, such as France. And on those countries, when EAS is in debate, on the other hand, withdrawing in life-sustaining treatment and palliative sedation are currently going on. So I guess if it could be there's some mistakes still on this map, because I didn't find it somewhere. I just built it myself, but it was. If you have any comments on if I have maybe some mistake on countries. quick overview on the started of the legislation in France. Started in the late 90s with the new law, which was the first to establish the right to receive care at relieving pain in all circumstances. Then quickly followed by a very important law on the right of access to palliative care. So it was the first time in France that the palliative care was defined, such as active and continuous care provided by interdisciplinary team with the purpose to relieve pain through psychological suffering, preserve dignity, and support the relative. So it was the first law that implemented at least the right of access to palliative care, not at all the facilities and the institutions, which is still a very missing and a very bad point of France, where absolutely no 100% of the population can have access to palliative care units. Then a second law in 2002, very famous and very foundative for the law in care in general. It was the law Kouchner, that we call it Kouchner, on patients' rights and the quality of healthcare system. So it's a very huge and very broad law, but in one of those article, it reasserts the principle of free and informed consent before any treatment, and the right to refuse, and therefore the duty to inform by the professionals, and the right to a dignified life until death. So it was the first step where you had on the same text, consent and the right to refuse. Then, beginning of 2005, after a big mediatic event, Jean Leonetti, which was a French deputy, wrote at after the president asked him, the first law on the rights of patients at the end of life. This law at that time affirmed that the patient has the right to stop or not initiate any treatment and active therapies that are deemed futile or disproportionate, infringing life artificially. So it has really been an important law and that has implemented the withholding or withdrawing life-sustaining treatment, even though if it was led to shorten the life. And there was also the medical futility who has been defined at that moment. Medical futility that could be originally by the patient or by the physician. So and then have this subjective appreciation. But then 10 years later, again, after another mediatic event of Vincent Lambert, Jean Leonetti was helped with Alain Claes to write a second law, and this time a little bit enlarging the first law, adding the right to palliative sedation, so continuous deep sedation until death. So it was really a sort of a difference between those two laws, which has never been really well understood, and of course, and actually never well been implemented. Doesn't work. And then it led again 10 years later on the draft bill that we are currently will be discussed on. September 2022, first move from the French National Consultative Ethics Committee, and it was like like a deflagration in the community, in the professional community of ethics, and they acknowledged that assisted dying could be considered in France within a very strict framework, provided that access to palliative care is significantly improved for entire population, which I have to say is absolutely not the case. So first, this was this, stone in the lagoon, and then a deputy, Olivier Falorni, wrote this report, essentially saying that this former law of 26th Claes Leonetti has never been implemented, never been understood, and then it was a need to go further and to go one step beyond. In December, they built a citizens' convention gathering 184 citizens from every social origins and profession They have sitted for 8 weeks, having audition, meeting people, professional, association of patients and families. And finally, they wrote a report which was mostly in favor of both the MAID and both the developing of palliative care. July, another advice from the French National Academy of Medicine, and May 2024, the Special Commission. This Special Commission was a series of auditions of professionals, of the same thing, association, palliative care societies, etc. It lasted for weeks at the National Assembly, except that there was no audition from any society from psychiatrists, nor any societies from nurses, which was not because we declined, but because we'd never been asked and never been invited. At the end of this special commission, a draft bill was published on a unique document on palliative care and MAID. But if you have followed the activities of France and the chaotic politics, Emmanuel Macron decided to dissolve the National Assembly in the beginning of June. Therefore, everything stopped. Suddenly, from the day 1 to day 2, nothing was ever worked again on that debate. So we had to wait a little bit less than 1 year to again restart the work in the Assembly. And so last end of May, there was a first text adopted by the National Assembly. This text was actually split in 2 parts. So the first draft was a unique document on palliative care and MAID. The second document accepted was one first document on palliative care and the other one on MAID, which for any kind of reason was the best thing to do, because of course everybody was for developing palliative care, but then could allowed some other voices to vote for MAID. And indeed, the text about MAID was accepted for 300 votes in favor, 200 against, and 57 abstention. So what is this draft? The bill of this first text on palliative and supportive care. It creates a new category of care, which is called supportive care, broader in scope than palliative or nursing homes or geriatric units, for persons at the end of their life with a personalized support plan. And it establish a new type of structure, which is called supportive care homes. None of them are still created, none of them are still financed, but they decided to have quite a lot of money to get those. The second bill on the right to MAID tells that the law authorizes and organizes the provision at the request of an eligible person of a lethal substance for self-administration, or if the person is physically unable, by a physician, a nurse, or a volunteer designated by the person. This made, to my point of view, the exception, a worldwide exception that covers both assisted suicide and euthanasia at the choice of the person. So it's really something very specific, I guess, that from France that will maybe pose some issues. The eligibility criteria are quite the same as everywhere. Be at least 17 years of age, French national, be affected by serious and incurable illness, threatening and life-threatening and in advanced or terminal phase, be experiencing physical or psychological suffering, either if the person is refractory to treatment or deemed unbearable by the person herself, and the person has to be capable of expressing he or her will in a free and informed manners. So for me, the outstanding questions about these, for instance, and that some questions that I can address to the group, and how to define unbearable suffering, as it's a so subjective aspect of emotional and in the speech of the person. How do you define time horizon with the words life-threatening prognosis in advanced stage? How do you define advanced stage without any 6 months, 3 months, 1 year, 2 weeks or whatever? And the assessment of decision-making capacity is not at all specified by whom and how and using right kind of criteria. The procedure is made by a written request. The physician should inform then the person about a health status, the likely progression of the illness, the availability of treatment and care options if there hasn't been attempted before, the effective access to suppurative and palliative care. So I have to say that more than 60% of the French territory is not covered by a palliative care unit. So it means that if you live in Paris, if you live in Lyon, okay, but if you live in the countryside or whatever in the suburb, it might be that you don't have any kind of access to palliative care units or even to mobile palliative care. Then you should be also informed about the condition and the modalities of assisted dying and the choice that you want to make. And the fact, of course, that if you want to withdraw your request, it is possible at any time. Then it's written that the physician can offer to refer the person to a psychologist or a psychiatrist. Nothing more is written. And this is also maybe a question that I can address. This is not compulsory. Then the procedure will be, I think, quite the same as any other countries. The physician can ask another physician not involved in the person care, which is a specialist of the illness which is concerned. He can also have the advice of an healthcare assistant, any other health professional, the trusted person. If the person is under legal protection, the guardian must be informed. I don't know about the other countries for the delays, but then what was written in the text is that a response is to be given within 15 days to the patient. And then the patient has only 2 days of reflection before confirm the request. I have the idea that it's a little bit longer in Belgium somewhere else. Then the information is given about the modalities and the designated healthcare professional who is going to be there at the right moment. The person then has to choose whether he or she wants to self-administer the latent substance, whether she wants to ask someone else to do it, or the presence of an healthcare professional. And if the confirmation of all this process is more than 3 months after the decision, then the procedure has to be restarted from all over again. The day of the procedure, the physician has to make sure again that the person is right to put this advice and wants to do it and not postpone it. Then it's written that the physician must remain in sufficiently close proximity to intervene in case of difficulty, which is to me a question. What does that mean exactly? And what does the physician has to do in case of difficulty? Should he has a substance or something else to do? And then there's also a clause of consciousness for any healthcare professional who do not wish to participate in the process. But also any kind of department must allow the intervention of healthcare professionals. So it should be able to be available in any other kind of structure. And also this healthcare professional who wants to participate to the procedure must declare themselves in a sort of a list to the Oversight Commission. So the question for me for that article is that, does it apply, because you might have those also in your countries, does it apply only to the professional who is going to perform really the act, or all the people and professionals involved in the procedures? And the conscious objection is allowed for healthcare professionals, but not for institution, not for pharmacists, and not from nurses, which is also a question that I can raise. And the establishment of a list of practitioners willing to participate might be a risk of stigmatization for professionals. There's a commission reports to the Ministry of Health. This is absolutely equal to all countries. It's a posteriori control. And it's so there's nothing very important to say about this. And this quite is, I guess, also very exceptional in France. There's an obstruction offense, which if you prevent to attempt or prevent the access and disrupt the access to institution, then you could be punished for 1 year or 15,000 euros fine. So it could be a question for some professional who wants to make some, it could question prevention of suicide guidelines in general, but I'm not quite sure. I have almost finished with some questions that could be addressed to us psychiatrists. So if in the text the psychiatric advice is not mandatory, then when will the psychiatrist will be solicited? Knowing that in any case, if we have enough trained psychiatrists available and willing to do so? And we have to know that in France, the waiting time for a psychiatrist appointment in public institution is between 2 and 6 months. So if we have to have an advice within 15 days, that we have a problem of feasibility, just, pragmatically speaking. How should we assess this decision-making capacity? Is it an expertise? Is it a primary psychiatrist who is able to do it? Is it a specialist and trained psychiatrist? On which kind of tools, stay clinical intuition only? So I have, pointed out that sort of a scale. Actually, the ACE is not translated into French to MACAT. Either MOCA, UDOC are in French spoken, but we don't have now actually validated French scale available. Would that be in a single consultation or several? We do have 15 days to decide. How can this be managed? What about the cognitive bias, the temporal variability and ambivalence in depression, but not only? And we also know that mental disorder does not always impair decision capacity. And what about the nature and the extent of psychiatric intervention already attempted before concluding that nothing more can be done? At what stage do we say we have attempted everything and now it is deemed and futile? Is it the sole reason for the request, for instance, comorbidity with cancer, with multiple sclerosis and other neurological disorder, that we know that pain and social isolation major the risk of depression and suicide? And maybe lastly, beyond the decision capacity assessment, what about the wish to die? We know that wanting to die cannot be taken at face value and that ambivalence exists. And we need to be careful about the difference between wanting to be dead or wanting to die or wanting to be killed. And I really think that nowadays psychiatrists in France are not at all ready to answer that kind of questions. And also I would be really interested to have exchange with you on that. The near future, as I have understood that your association will be only working on that, it's likely that psychiatric disorder now are excluded from the bill, but will soon be included as eligibility criteria, as it is the case in other countries with the slippery slope theory. And the concern raised by other countries invite reflection about the issue of decision capacity, the temporality of psychiatric disorder, the risk of impulsivity, the existence of personality disorder, eating disorder, where suicidal behavior is common, even without associated with depression. The difficulty, as I said before, of distinguish between suicide request and rational request to die, if we can say so. The necessity, of course, of a proper and specific training and ethical approach. And the message that maybe could be heard like society, that could be conveyed by the society, that the life of a person with disability is worth less than the other ones, and it's better to be dead than disabled. So how to change this message and how to avoid that. And a final question to you: as the legalization of MAID in your countries influenced the rate of suicide attempts or death by suicide? And has it changed the effort or the financial investment towards suicidal behavior prevention programs? So with all that questions, I leave you and I thank you very much for your attention.
Yeah. Thank you very much, Cecile, for this excellent presentation with a lot of questions and a lot of information.
More than answers.
Yeah, but it's a very good overview of the situation in France. First, let me see in the public. Is there any question for Cecile about the situation in France?
Yeah, I have a question, Richard Oudefossa from the Netherlands. Hi, Cecile. Thank you very much for your perfect presentation and to show us the situation in France. I was wondering about the comorbidity, because you speak about what about if it is cancer and depression? And in the Netherlands, we have an opportunity to perform euthanasia in case of an accumulation of health deficits in later life. So it's generally diuretic syndromes, loss of visual acuity, hearing decline, etc. And in clinical practice, I work also as a scan physician, so I see a lot of patients just in the weeks prior to their euthanasia. It comes to me more and more that people with accumulation of health deficits also have some psychiatric problems, and they might also be sometimes a little bit subthreshold. And last week, for example, we had a case, and we were in our supervision of the scan physician, we could not agree on whether she fulfilled the criteria. And the problem was she had an accumulation of health deficits, but it was a little bit on the border whether you should allow it. And she had borderline personality pathology, but not that very severe. And if you count it, you can say it is allowed, but if you say, well, that might be a problem or it might compromise the physical capacity, I don't think it doesn't. You can also say, no, in that case, we shouldn't give euthanasia. And it was a very difficult decision. And can you imagine how the French law will deal with it? And do they say something explicitly about accumulation between the threshold and diuretic syndromes?
No, they don't say anything about this actually. But this is the first bill, the ever first bill. So we do hope there will be lots of amendments, and I do hope also that there will be more reflection on definitions, because it's only written, life-threatening pathology. So there's nothing very specific about how do you define those. And from the psychiatric disorder itself, it is excluded nowadays. But it says psychological or and physical suffering. So there's nothing very explicit about this. And I'm also very, we are not ready at all to welcome that kind of demands. Actually, I'm working in a mobile team of all-age psychiatry. So I go to nursing homes and to homes to meet people without, with the aim of delivering access to care. And every day people say they want to die. Every day they want to die, but you have to also be very specific about this wish to die and expression to die, because I want to be dead because I'm old, I'm alone, nobody's going to see me, I'm suffering in my bones, etc., etc. But even though without any depression, it is not at all the same thing saying I want to die, said I want to be killed. So and my concern is that we as psychiatrists absolutely are not ready and not trained to make this difference. And so the most fear would be that without knowing and with being, not aware of things or not even concerned, many people will be maybe over accepted and with the eligibility criteria. So it's quite a concern right now. I do hope that the law will evolve. Now it is going to be studied by the Senate at this fall. So maybe we'll have to wait for one year approximately before the law will be published, but it will be published. And another fear is that we as psychiatrists will not be involved, and this will be really a shame. So we do have to raise our voices and make things happen in order to be heard, because I really think that we do have things to say.
Yeah, please. And can you tell me, because you told us that in 2024 the psychiatrists were not involved in the special committee.
We voted them.
What is the position of the French Psychiatric Association in this topic?
The problem that we have in France is that we don't have only one association, but we have 39. So
39?
it is always yes. It's always a problem with this French diversity. So it is one of the action is to gather the advice and to make people speak of one voice. And of course, there's no one voice because you have lots of psychiatrists who are firmly against and lots of psychiatrists which maybe not so much against, but without not enough voice. So for now, we do have heard psychiatrists which are really against and who are afraid that all the work on suicide prevention will be just vanished because of this law, and then the vulnerable people has to be protected. So I must say that there is no official position of the psychiatrists. We have published quite a lot of paper. We have, built collective and thinking, but absolutely impossible to have a unified voice. So I cannot say that there is a position. But I mean, the Academy and the French Federation of Psychiatry has written to the Parliament asking for an addition. It has been said no, because you psychiatrists, you deal with suicide prevention, so you don't have a word to say on MAID. And actually also, yes, this is what was answered. And on the other hand, the Patient Association have also replied, we do not want this to be psychiatry. We don't want psychiatry to be involved because this is not a psychiatric issue. This is a social and a cultural and a personal issue. So with those two aspects, then psychiatrists, they couldn't be heard.
But you also
I see, Kenneth, that you say, wow, but I mean, I mean, it's a complexity.
Maybe just to follow up on that, and another question that I had is because you're saying that about the law is going to come, but a lot of countries have also implemented an implementation period. So it's not because there's a law that you have to initiate it immediately, that it gets embedded in practice. I think Canada has done that, in Australia the same. So that might be a good option for France as well, because you say you're not ready, especially in the field of psychiatry. You would probably need a long implementation period to get everything in order, to get everything sorted, and to get all the noses in the same direction about how all these requests will be assessed.
I don't know.
There's no talk of that.
No, it's not advice. Okay, thank you. Chris. Hi, Chris. Good afternoon for us.
Merci, Dr. Henon, for a great presentation. Chris Kittamara from Canada. You just mentioned the delay. I'll just point that can be a very long time. In Canada, it started as a 1-year delay, and now they've delayed it 3 more years, now into 2027. So we're looking at that delay just for the mental illness piece at 4 years. And, I think it speaks to the complexity. But my question was going to be around the proposed laws as it relates to treatment refractory in France, and whether the condition has to truly be refractory, as in trialed all reasonable treatments, or in the case of Canada, it's only that the condition has to be refractory to treatments that are acceptable to the patient, right? So if we're thinking ahead for mental illness, and someone with severe depression in Canada, while we're not there yet, it's proposed that if the patient does not want to have ECT, for example, that the condition may still be treatment refractory, because that's not acceptable treatment. Although I know that would evoke, I think, more moral distress in us as clinicians, right, to accept that irremediable condition. But in the proposals in France, is there that condition that, like, does it say it has to be truly refractory to all reasonable treatments?
It does, but it is not specified that it is from the point of view of the patient, which I understand it is in Canada. So no, it is not written as such. Because actually I think we've written this law, the bill, they have just thought of, cancer treatment or cardiologic treatment or other kind of treatment, but not at all psychiatric treatment. So that's why.
Thank you.
Thank you. Any other questions? Richard?
No, I can make a remark on your question related to suicide. I recently put the figures on suicide 20 years before the introduction of the Dutch euthanasia law, the year itself, and 20 years later. And we see, if you see at the figures, you don't see a decrease after the 20 years that the law was introduced. You see a general decline in older age, but I think that started already from the 80s. So I think that's better palliative care in our country. The only exception is the old males around 80 and above. We have seen a decline after the introduction, but whether you can make that relationship is not clear.
And about the national programs of prevented suicide?
I couldn't see any decline.
Difference, okay.
Thank you, Richard. Kenneth.
Yeah, I was also going to jump on that. Well, it's the suicide contagion argument, or the suicide substitution argument is also there. I'll say a little bit about that in my talk.
Okay.
But as Richard also said, it's very difficult to establish cause and effect here, because suicide numbers will vary greatly in time in every country, depending on the social circumstances, economic circumstances, things like that. Those are more influential, I would say, than a law on MAID. And right now, Neil Francis from Australia is making his PhD on this specific question. So in the coming year, maybe 2 years, he will have some publications to. He's doing a literature review at this moment to gather all the available evidence on that. And I also can probably direct you to a paper that was published not so very long ago, a few months ago, from Canada. I'm not sure who exactly published it, but they also analyzed the suicide numbers in Canada and didn't find a relationship. So it was inconclusive. That means that probably suicide contagion and substitution is a non-issue.
It's not an issue. Okay.
Yeah, and it's probably much more influenced by all different kinds of societal
factors, risk factors.
And in Belgium, we have seen, I think, an increase in suicide prevention efforts because of the practice of euthanasia and psychiatry.
Okay.
But I could direct you to a few people in Belgium will be able to say more about that.
That's in a sort of way reassuring.
Okay. I found more questions, Cecile. You're talking about the legislation, and it's only on somatic grounds. And then you have a question about the role of the psychiatrist in assessment of decisional capacity. But is it in France that in every patient the psychiatrist will assess the decisional capacity?
It is not specified who is going to assess that capacity right now at the moment. So my question will it be a psychiatrist, and therefore it has to be mandatory to have psychiatrists at least to assess capacity of the site, and maybe to assess more, like the existence of a mental disorder impaired that should impair the ability to decide or whatever. But no, it is not at all written what kind of professional should then assess the capacity. Currently, psychiatrists are involved for seclusion and detention and care without consent, of course. So this is a daily basis that every psychiatrist know how to do that. And they are also solicited for guardianship. But there's no way now. So and also you have there's another pragmatic thing that we don't have enough psychiatrists to trained and interested and willing to do so to be able to assess, and we don't really know what kind of other kind of professional is going to assess. And which,
but in the Netherlands, it's when there's euthanasia on somatic grounds, the doctor says the decisional competence, and also an independent
GP,
doctor, not a GP. Or not a psychiatrist. And also when there's involuntary help for somatic diseases, not a psychiatrist is not consulted all the time.
Exactly.
No.
Yeah,
I know.
Yeah, but can I add something? Because because we have the system of scan physicians for support and consultation euthanasia in the Netherlands. They are usually GPs, but they are the independent one. They have duties. So if you call them as a GP, if you want to perform euthanasia, they can come the same day or the next day, and they are trained in decisional capacity. So you have always a check, and if it is not clear, in that case, you can always advise to consult a psychiatrist or a specialist in dementia, for example, if it's complicated cases. But in reality, decisional capacity is not a big issue. No. It is often quite clear. So if you ask, if you would say a psychiatrist, would we judge every case? I think it would be stigmatizing for most of the patients who receive euthanasia, to be honest.
I agree with that. And only for psychiatric grounds or for dementia, from professional guidelines, an expert must assess the decisional competence. But in any other cases, what Richard says,
so only for psychiatric disorder and
dementia. Yes. And when there's any doubt about decisional capacity by the GP.
And your GPs are okay with this? Or the scan physician, there's no problem with that?
No.
Okay, and they have tools?
Yes. Okay. Kenneth is adding some research in the chat.
Yeah.
And are there any other questions for Cecile or answers on the questions that Cecile asked us? Because
time is going.
Time is going. So I think we will discuss this topic in the other network meetings when the next time in September. Chris and Cindy from Canada will present their legislation in Canada. So we'll discuss such topics, I suppose. Thank you very much, Cecile Hanel, for this very interesting presentation and discussion. Thank you so much. We go to the next presenter. The next presenter is Professor Kenneth Chambert. He's Secretary and Vice President of the IAADM and has portfolios of research, education, and perspectives of patients and relatives in the IAADM. He's a sociologist and interdisciplinary professor of public health, sociology, and ethics of the end-of-life and end-of-life care research group of Ghent University and University of Brussels. Your research focuses on three main themes: end-of-life practices, palliative care in and by the community, and end-of-life care for people in vulnerable positions. You have published many international peer-reviewed papers and wrote also several chapters of book chapters, for example, the Dutch Handbook about Psychiatry and the End of Life. Most of your recent current research is focused on assisted dying and euthanasia in persons with psychiatric disorders and dementia, and we are very happy that you will tell us about your research about concrete experiences and support needs regarding the euthanasia practice in adults with psychiatric conditions. So, Kenneth, are you ready to start your presentation?
Yes, thank you.
Okay, great.
Thanks for the elaborate introduction. Very nice. Just see whether I can share my screen. Are you seeing this? Yes? Okay, perfect. Right, so Yes, also welcome from my side, everyone, and thank you for allowing me to present this work that is actually not very much of my doing, but mostly of Monica Verhofstadt's doing. Radboud already said in the beginning, Monica was also part of the start of IAADM and was also my PhD student. This was part of her PhD work. She did, of course, as you all know, PhD student does all of the legwork and all of the research work. And as a promoter, supervisor, you're very honored to see them perform the work and to get the results together. So it's maybe a shout out here to Monica. Thank you for all her work that she's done in the past, and a pity to see that she had other things to go to. So my talk today is on the concrete experiences and needs of healthcare providers in Flanders, in Belgium, and maybe just to bring you up to speed for those who don't know Belgium very, very well. A little bit of background on our euthanasia law, which is, of course, just euthanasia, just assisted dying where the physician performs the act, although it's also condoned, let's say, to perform assisted suicide, although it's not very explicit in the law. We have the law since 2002, and very similar also to other laws around the world. But of course, one big exception that we have with the Netherlands and Luxembourg together, and maybe now also France in the future, that is that our law is pretty liberal in the sense that it does allow for euthanasia on grounds of non-terminal and psychiatric conditions. So what do we know from practice at the moment? That there are annually actually only since 2011, euthanasia in psychiatry has been being reported to the Federal Committee for Euthanasia. So the FCECE, that's the Federal Committee on Euthanasia that reviews all the cases. So annually up to this point, we have a few dozen of cases reported annually. But we also know from our research, from Monica's research, among others, is that the number of requests is a multiple of that. And we have reason to believe that the granting rate, so the rate of requests that actually go to performing euthanasia, is less than 10%. So, and we know, of course, from our research, we can explain the low acceptance rate because the acceptance rate in cancer is about 75%, so a lot higher. We know that's the case because it's, of course, a very controversial, controversial cases, complex in terms of its assessment and management. And our research has also shown that there's a lot of reticence, reluctance among physicians and care teams in the psychiatric field to engage with the practice, not just to perform the euthanasia, but also to engage in assessment and decision-making. So we know that from our study among members of the Flemish Association for Psychiatry, 75% of physicians or psychiatrists who participated said that they were on board, let's say, or they felt that it should be a legal option for people with psychiatric problems, but only a very small fraction was willing to go to the end with their patients in terms of these euthanasia requests. So it's professionally and emotionally taxing. We know that from, again, from research. And of course, for those of you who don't know, in 2019, there was a very influential court case, a criminal trial. 3 physicians were put on trial for the death of Tine Nys. So she received euthanasia, but years after the family started a lawsuit and they were charged with manslaughter based on poisoning. So they were acquitted in the end, but you can imagine what a shockwave that it generated across the medical field, actually, not just the psychiatric field, but the medical field. And so we have a lot of guidelines now, or a growing number of guidelines, and also consultation centers. So centers that are, have built up expertise and experience on specifically euthanasia and psychiatry. So the guidelines generally do 3 things. Well, 1 to 3 things. This either they help with clarifying legal criteria, which is also is a good thing. They can also make criteria stricter than the law imposes, just to add to due care in their view, and also they introduce new criteria. So not unimportant to know as a background for the study that I will be discussing right now. So this is a snapshot, or let's say a slide of all the organizations that have to some degree or to a large degree been embedded or been involved in euthanasia practice in psychiatry. So you have the Flemish Association for Psychiatrists. Also, the Order of Physicians has issued advices, not very influential, but we'll mention them anyway. Rea Piro, Ultiem, Vonkel, Broeders van Liefde, so the Brothers of Charity, Recht op Waardig Sterven. Those are all organizations or expertise centers that accompany patients with a euthanasia request. So I won't go too deeply into that. It's just to give you a general background of the lay of the land, let's say, in Belgium. And just as a reminder also that Monica's research was much larger than what I will present here. I'm just presenting the last of her several analyses, and you can, this is the reference of the talk of today, and also the second point is her PhD, which you can download digitally on our website. Right, so going into the study of, healthcare professionals in the psychiatric field, and on the one hand, their experiences, and on the other hand, their support needs, or the recommendations that they have moving forward. So what we did was a qualitative interview study with, of course, the target population being physicians, both psychiatrists and other physicians we allowed. And we'll see that we also have a few general practitioners in the sample. Nurses in psychiatry, and also other health professionals such as psychologists, also moral consultants, things, people like that, and also non-professional, because in this type of practice, there are a lot of volunteers active in Belgium, and also we call them buddies in some organizations, and they're also consulted because they have also their own specific perspective that professionals often don't have. So yes, these professionals needed to have experience and or involvement in at least one euthanasia request based on a psychiatric condition. At least one psychiatric condition. We know again from statistics that the cases that go to a euthanasia in the end have multiple comorbid psychiatric conditions. We did recruitment via different channels, and that's very important because in Flanders, at least, there's quite some ideological influence still in terms of being pro, being contra. So we wanted to recruit from all the different organizations with all different signatures and different takes on the practice of euthanasia, especially in psychiatry. There's a lot of difference of opinion. So that helped our heterogeneity. And of course, we followed all ethical guidelines, and our analysis was inductive, thematic analysis, and to the point that we reached saturation on the main themes, not always on all the sub-themes, but the main themes were there. Right, I hope this is visible. It's a bit small, but this is the makeup of our population that we reached and that participated in the study. We had 30 people in total, 16 of which were doctors and 14 other healthcare workers. And you can see down at the bottom that, let me just see, yes, the 16 physicians were mostly advising physicians, only one performing physician. So that already shows how very few physicians engage actually in the procedure of euthanasia. And we also had a lot of variation in terms of the care workers or the healthcare workers in terms of their background and also in terms of the environment that they are engaged in. So we were pretty happy with our sample in that sense. Right, on to the results, the main results regarding experiences. We identified inductively 8 domains of experiences. And you can see them here, the influence, let's say, on the clinical trajectory, the influence on the relationship between patient and provider, experiences related to team collaboration, to the role of the social circle, collaboration with centers, the use of guidelines also, the impact of trials, let's just say the impact of that one trial. It's also on the very much on the forefront, let's say, of a lot of people's minds, and also experiences related to performing euthanasia. And so I said that we analyzed the data inductively. So these were 8 domains that came from the respondents themselves. We didn't impose those domains, it's important to say. And also, when we go into these different domains, what seemed to fit best for us was a division between positive experiences and negative experiences. So that's the way we've structured the results in the paper, and that's also the way that I'll be presenting it to you. So either people were discussing it in a positive way, or certain aspects in a positive way, and others were more critical of the way that things were going and how they had experienced it. So we made that division throughout in that sense. Okay, so the first one is the influence on the clinical trajectory, and we've also we've divided that further into the 2-track approach, window of opportunity, and suicidality. So the 2-track approach was mentioned, and it's, maybe I should also clarify, this is kind of an adagium that's being advocated for across Flanders to have this 2-track approach. What does it mean? That it means that if you have a euthanasia request, that the physician doesn't just explore the euthanasia request, but there's always this this continued focus also on the life track. So we speak of the death track and the life track. And positive experiences related to the 2-track approach were that it offers, of course, continuity of care. If you don't have that, then maybe the care can break down. Feelings of non-abandonment, or let's say feelings of abandonment, are also avoided. Tunnel vision is avoided, and it also opens the floor to new treatment options, and also in terms of in terms of that window of opportunity, which I'll get to in a bit. There's also a few negative experiences related to that, and that's that it can thwart access to care. And we had a few physicians and nurses telling us that when patients voiced their request, that some people in the care team refused to care for them or treat them further because they had this death request. Other people said, yes, it's good to have a 2-track approach, but in some cases there are just no recovery options. The patient is very far along the treatment course, and also the combination with the lack of a palliative approach, or a lack of palliative care in psychiatry was a negative experience in that view. So you can have this 2-track approach, but it doesn't really help the patient because there's nothing to offer, let's say, in the life track anymore. And others said that the life track can be an extra burden for the patient as well. Window of opportunity, it definitely, so a euthanasia request definitely opens that window of opportunity for serene, in-depth discussion about the death wish. It also, having an exit plan or having this potential way out of your suffering via death can have a therapeutic effect as well. And that's what I meant with patients being willing to explore new treatment options again. So you re-evaluate your treatment as well. Others said that the law on euthanasia does not, or does narrow actually the window of opportunity, because it demoralizes patients in that they feel they need to request euthanasia. And then coming to the point of suicidality in terms of clinical trajectory, also important. There were physicians and care workers saying that they did see suicidality feelings and behavior diminished in their patients while they were assessing the euthanasia request, and others said that there was actually no real effect to be found on suicidality. Right, and this is just an example or a quote, to illustrate new equilibria, meaningful balance that can be refound within these euthanasia requests. Second domain was the influence on the patient-provider relationship, positively in terms of enhanced connection, better trust between patient and provider, and also better contextual understanding of patients. So you go very deeply into their life world. Normally, you do that in a therapeutic relationship, but when you open up to the idea of death, then it gets really, really existential, let's say, or really deep very, very quickly. And what we also found in our research with patients is that talking about death, talking about it openly, also makes them feel heard, understood, and respected in their suffering. So it really helps the relationship along if the physician and the care team is open to it. But of course, there's also negative effects, negative influences in terms of, yes, so when you go that deeply with your patients, it's also starts to get difficult to set your boundaries and also adopting an appropriate attitude because you get very close to that patient. And then, it also leads to other possible issues, of course. The therapeutic relationship can come under pressure, of course, in that relationship when you're talking about death. And in case of rejection, there were people saying that there was insufficient aftercare because of the fractured relationship that ensued because of this rejection. So things to ponder over, but one quote that we also published in our paper was that for some physicians, it's actually a privilege for them to get very close to people in that short space of time. Team collaboration, yes, again, positive, negative experiences. People really appreciated the opportunity for intervision and support that builds knowledge and expertise, and also gives a sense of coherence within the team. Let's say it's kind of a calibration as well on how to handle and how to position yourself against these euthanasia requests. And also, because you're in a team, you can share responsibility, workloads, and impacts. I guess that's pretty obvious. Negative experiences are mostly in the case when there is a lot of difference of opinion, and then colleagues can get stigmatized to some extent when they are, have a positive attitude towards a specific request or towards euthanasia in general that might pose problems within the team. Also, in terms of collaborating within the team, some irregularities were mentioned. So the lack of a meaningful referral or advices that come in that are insufficiently detailed where the assessing physician isn't really helped with. And then also bad management and follow-up, lack of room for discussion, supervision, intervention, and support. So actually the opposite of having that. Right, so also not too bad if you have a team that is supportive of each other, let's say. And just to illustrate a little bit how things can go wrong for the patients, if there's a difference of opinion and a physician gives an approval and then the other one says no, if that person is giving approval, I don't want to be involved, and then the patient is left in a kind of in the middle, right, and is not helped at all. So that's a really good illustration, I think, of how things can go wrong within the team and how that affects the person whose request is under review. Then role of the social circle. There's also few papers been written on that, the involvement of the social circle. Positive experience in that sense was the fact that promotes mutual understanding and also the potential to restore relationships that have been fractured in the past, right? That's also something that patients in our interview studies have said themselves. Another point, let's say, utility of the social circle is the heteroamnesis, in the sense that they can offer an understanding of the life world of the patient when the patient is not as well able to voice it themselves, or is unwilling to say certain things. So it's about completing the puzzle in that sense. And also, when they are involved and it leads to euthanasia, there's time and space for the social circle, for family and friends to prepare for the death, because it's also always very, very impactful for the social circle. And on the other hand, when patients refuse their involvement, that's actually a negative experience by a lot of healthcare workers, because they ideally want the social circle to be involved, of course, for different reasons. And I think the case of Tina Naes really highlighted that when you don't do that, even years after, you can still get yes, not sued, but there can be a criminal trial installed by the family who are bereaved. And also, when you don't involve them, of course, there's little time for acceptance. Sometimes they don't know until the final days, or they don't know until after even, and that's it's a very negative experience for the healthcare workers, but definitely also for the next of kin. And so this is a quote just to show or illustrate a physician grappling with that issue, that if the patient doesn't want their family to be involved, what do you do? How can you try to convince the patient that it is something that can be worthwhile to do? Okay, then a few others that I've put into one slide. One domain is on collaboration with consultation centers, so the expertise centers, mostly Vonkel and Ultiem. So those are the two main ones, let's say, in Flanders, which are targeted when patients don't have their request heard by their physician. So it's a fallback option when the treating physician refuses to assess the euthanasia. Of course, that's not ideal, but for those patients, it's very thankful to have this consultation center, someplace they can go to. And for the professionals who do assess or who do treat and follow up with the patient who has their euthanasia request, it's a crucial extra partner for those who are less experienced, especially in these cases. And negative experiences had to do with difficult collaboration, including different approaches and ideological bias, which I've already highlighted a little bit in Flanders. Also, sometimes consultation centers have been found to take over the entire request, the assessment of the request, and then the treating physician who is willing to be involved feels sidelined. There's also some mention of unprofessional conduct or behavior or follow-up within the centers. And also, this is something that's come with the years and with the success of these centers, that they're overloaded at the moment. They have long waiting lists. So I heard Cécile say, if you want a consultation with a psychiatrist, you have to wait 2 to 3 months, I think. I think for like a center like Vonkel in Ghent, if you apply as a person with a euthanasia request, you can wait up to 6 months to have your first consultation in that expertise center. So it's a very, very big problem of capacity, I think. And it's the same, I think, in the Netherlands as well with the expertise center. Use of guidelines, positive experiences, that is useful, of course, in assessment. It also provides some kind of authority, creates trust among physicians if you can find it in these clinical guidelines. how to conduct your assessments, and also additional conditions meet the concerns of a lot of physicians, so they can actually use these guidelines, or these guidelines are more in line with the way that they want their euthanasia practice to go. And of course, negative experience as well. It's not always convenient, redundancy, impractical advice, vagueness in advices, and also blind spots. That's also been highlighted in one of Monica's other papers as well. Some guidelines to some professionals are biased. I don't know, I don't recollect in which way again. And there's also lack of uniformity across guidelines. Because you have different guidelines, there will be different accents, and then you lose the uniformity a little bit. Then impact of criminal trials. I don't have to repeat that. No positive experiences were mentioned there, and a few negative experiences. So a lot of colleagues getting cold feet, no longer wanting to be involved. And also some said that because we had that criminal trial, it was very, very polarizing, and there was no more possibility to have an open and nuanced debate on that. Then the last
5 more minutes. Sorry, this is the last slide. Okay.
Yes, this is the last results slide. So 5 minutes, thanks. I'll try to keep the time. So the performance of euthanasia, positive experiences had to do again with the beauty of certain moments between the patient and the physician and the loved ones, and also gratitude that's been shown by patient and loved ones. So that's kind of a very important aspect, I would say, for a clinician to be involved in this, is to see how it can end in a good way as well. Not only in euthanasia, but it can end in good ways otherwise as well, of course. And negative experiences were that poorly executed euthanasia. We hear about that from time to time. That's something to really look at. But yeah, there's also been a few testimonies of patients changing their mind at the last minute, and that can weigh very, very heavily on the clinicians. There were a few people who said that, and that really sticks with them. Of course, the patient is always entitled to do that, but when you've run your course, a very long course with everyone or with that patient, that makes it very difficult to stomach when they pull out of it in the end. Right, there were also 8 domains on support needs. Don't be afraid, I won't go through all of them like I went through these experiences. I know there's not a lot of time or not enough time to do that. But these were just some recommendations or needs that were voiced again inductively. So we grouped them according to the different domains that we identified. So people asked for protocols for subpopulations, such as people with certain complex comorbid conditions, people with intellectual disabilities. What about people in prisons, internees? What about intercultural or people with specific cultural backgrounds? Also, what you do, how can you manage people with manipulative tendencies? Things like that are important for some to add to the protocols. Guidelines for non-physicians as well was also voiced, and a true implementation of the 2-track policy, because it's something that's more elective or more optional for physicians to do. Patient aftercare specifically, of course, when the euthanasia request is rejected or is withdrawn, very important to be able to support that patient in the aftercare, and that's something that's very much lacking at the moment. Professional well-being is an important need that was voiced. How to involve the social circle as well, and training, support, and funding and resource. Funding and resources is always a support need that's, I think, universal. Right, so I won't go more deeply into that, just the conclusions. Drawing from the paper, I think we can provide a comprehensive and also a balanced overview, positive, negative experiences in euthanasia practice in Flanders. We might have a smidgen of selection bias because, of course, with such a touchy subject, you tend to recruit the people with the most extreme experiences or the most extreme opinions. It's not that we didn't have any respondents who weren't very balanced in their views or in their experiences, but we exceed that or can see that as a potential selection bias. What we do draw from our research is that outsourcing assessment is often not the best move as a physician and as a care team. It's best to treat that that euthanasia request within your team, because there's all kinds of complexities involved in passing it to another physician in center. Also, the 2-track policy was something that many people valued, but was still not very well implemented or not very well embedded in practice. And also regarding guidelines, we can ask the question to what extent they really help practitioners, certain aspects which are insufficiently elaborated, and also, the diversity of cases is maybe not captured in the current protocols. Right, and so I'll end it there, and thank you for listening. Sorry for being a bit long in my speaking. I think there's still 10 minutes for discussion. Thank you.
Thank you very much, Kenneth, for this very nice, very interesting presentation about the research with Monica. Are there any questions from the public for Kenneth about this study? I have one question about the guidelines. You are telling there are different professional guidelines, but what kind of guidelines are regular in Belgium? It's not only from the VVP, or how do you call it? What kind of guidelines do you have?
Monica analyzed, I think, 5 different guidelines, and those were still a subset, let's say, because there's very local guidelines as well. You have different hospitals that have different guidelines, all their own specific guidelines. So you have the most authoritative one, I'd say, is the one from the Flemish Association for Psychiatry. It's also the most elaborate one, probably the one you know in the Netherlands as well, because it's very much based on the Dutch one. There's another one from the Brothers of Charity. That's a guideline which is issued specifically for their institutions, and Brothers of Charity have a lot of institutions focused on people with psychiatric conditions, of course. So they use it as in-house guidelines, but I would say there's a lot of overlap, of course. There's a lot of differences again. Those are 2 big ones. The Order of Physicians, so the National Order of Physicians, they've also issued an advice, but that's actually not a very influential one. It's very superficial, let's say, to some extent. And then you also have these local protocols, and we were able to get our hands on the one from Ghent University Hospital for our analysis. And that was already very difficult because they keep it very close to their chest. And that was more about how to triage, let's say, and how to manage the process within the university hospital. So not very much focused on the content.
But as a psychiatrist, it's quite difficult what guideline is leading.
Yes. Well, I'm not in clinical practice, but I would say that the one from the Flemish Association is the one that is most well known and also most respected, most used, I would say. But I'm not sure about that. Maybe there's another Flemish clinician on the call who can speak to that. It's just that we know about the existence of all these protocols.
Okay, thank you, Kenneth. Richard.
Yes, thank you, Kenneth, very much. I was triggered by the positive and negative experience of the professionals, because a lot of words that it deepens the patient professional or therapist relationship, but also that the therapist feels under pressure. And I was wondering what is meant by feeling under pressure, and whether it was present in the same therapist, so it's a little bit paradoxical, or is it just more or less 2 subgroups? Because if it are 2 subgroups, should it be more educated and training in how to deal with these problems, and then that negative side effect will disappear? Can you comment on that?
Yes, from my recollection, these are actually different cases. So you don't have that paradoxical experience. And I think the negative experience, so the therapeutic relationship coming under pressure, comes mostly from teams and physicians who are quite dismissive towards the request. And then the entire relationship between the patient and provider comes under pressure, including the therapeutic relationship, which was there all along, right? So that's what's meant with that coming under pressure. So as a physician, as a psychiatrist, you can have a patient voice their euthanasia request. You could try probably to be very respectful in declining to be involved in that and referring them, but then the patient is also becomes very wary towards you in your therapeutic relationship as such. That's something that was voiced quite often.
Yeah, that's very clear. Thank you.
Okay, thank you. There's space for one more question from the public. No. Then we will end this session. Thank you very much, Kenneth, for this presentation. Very interesting research. So we are ending this meeting. The next network meeting is in September, the 19th, and I've arranged with Chris and Cindy from Canada that they will tell us about legislation in Canada and the situation over there, and we will have a very interesting speaker also about research or clinical care. We will arrange that also. And so tell all the people, all your colleagues about these meetings from the IAADM, and spread the news. If you want to be a member of the advisory board, please mail us. So we will install the advisory board in September. Thank you very much for the attendance. And in the chat was Florian that wanted to. Yeah, Florian, please, can you tell us? You want to highlight the debate?
Yeah, not much to highlight there. Just it might be interesting for the members that other organizations have directed their attention to the issue as well. So there will be a discussion on MAID in neuropsychiatric diseases and dementia organized by the International Psychogeriatric Association, IPA, soon on June 25th. So I sent the link where you may register if you're interested.
Thank you very much for highlighting this event, Florian. Thank you very much, everybody, and hope to see you in September. Thank you. Bye-bye.